Who can refuse? And this is the part where there may be a little bit of question. So any patient may refuse care who is A, competent, and B, shows capacity. So there are different definitions and understanding of competency and who a competent person is. So the example here on the screen, adequate but not outstanding or exceptional, properly or sufficiently qualified, capable or efficient, or legally qualified or sufficient. That would be the definition of competent from this particular example. When we look here from a legal competency and whether the patient has the ability to competently make a decision on whether or not they should stay in the hospital for like a psychiatric evaluation, competency, only a judge or a physician may determine competency. So from a legal standpoint, 72-hour holds is kind of where I'm going with this. This may be left only to a judge or a physician, as we are effectively holding someone against their will. So that is one example of competency. Competency from the medical portion is the legal capacity to perform an act and understand its impact. So medically speaking, it's agreeing to refusing care or allowing a procedure, testing, those types of things. So if you've ever had any type of testing done, when they come in, it's like, okay, you're here to have a CAT scan today. Are you okay with me doing your CAT scan? They are looking for competency, and that's why they ask some of those questions and to make sure that you're the right patient. So competency, a person is competent to testify if he is able to perceive, remember, and communicate, and believes that he is morally obligated to tell the truth. Again, this is another legal definition, which is different from the first legal definition and different from the medical definition. So the question then becomes, so who is competent? Initially, you and I, when we're making these responses, we should just presume that everyone is competent, right? So under normal conditions on the initial interaction, we may determine that the individual is a minor, that they're under the influence. But as we approach people, generally speaking, we should just kind of presume initially that that person is competent. And then when we figure out that they are not competent, and I'm going to explain this further and what that means, then we have to have other policy, procedure, protocol that we can kind of fall back on too. So there's something called surrogate competency, and these are guardians or parents of minors that have the authority of directing care. And by the way, guardians may not withhold resuscitation without a DNR or other legal paperwork. This is not my opinion. This is a legal opinion. So if you show up in a situation where there is a child that is in cardiac arrest, and it is a situation where this is a workable code, the parent there, just because they're the guardian, does not necessarily mean that they can say, I don't want you to start. In that situation, you have the legal authority to do what you think is right. It would fall under an implied consent because of a resuscitation type situation. Clearly, you get there, little Johnny has a scraped knee or a little cut, mom or dad or the guardian says that they're okay and they don't want them transported, then that's a different situation. In the event that you have any questions about that, contact law enforcement, contact medical control, and get other individuals involved, and then just make sure that it all gets documented appropriately. All right, so capacity is something different. So we talked about competency, now we're talking about capacity. So capacity, by definition, the mental or physical ability, the ability to retain, hold, and assimilate. From a legal capacity, relating to the soundness of mind and an intelligent understanding and perception of one's actions. So what are we actually talking about here? The question is whether the patient has the capacity, which is ability, to understand the risk of refusing care and or treatment. So how do we normally get refusals? If I were to ask any of you individually, what do we have to do in order for the patient to refuse? Most of you would say, well, they have to be alert and oriented, times, person, place, time, and event, right? And as long as they are, then they can refuse treatment. And that is what we've always kind of done, and that's what the perception has been, and there is truth to that. But that's not really what is allowing us to get the refusal from that individual. So a patient that has dementia, a patient that has a head injury, intoxication, drug use, those types of things. Does this mean that the patient does not have the capacity to refuse? There really should be a question mark at the end of that. I have had patients that are under the influence of alcohol that are still alert, oriented to person, place, time, and event. So they have a GCS of 15. Are these individuals able to refuse treatment? And that really becomes the question. So the ability to know the time, date, and year, or knowing the above, does not determine capacity. And when I was looking through here, it's kind of like, what? But after I thought about it, it really does make sense. So in order for us to be able to truly get a refusal on the individual, it is about their understanding of the medical situation at hand. Now, if they're not alert to person, place, time, and event, then clearly I think that we can say that they don't understand the medical situation at hand. But just because they are alert to person, place, time, and event, that still does not mean that they understand the medical situation at hand. And if you think back, the EMT instructors were really good about this, because I remember going back to my EMT training and being taught this information. You have to explain to the person the medical side effects. This is what we think is going on. These are the side effects if you do not go to the hospital, right? Up to and including death. And I think that it is appropriate and really needed to use information like that. So if you get there, you know, the classic, and we always become the middle person, right? The wife calls for the husband, or the husband calls for the wife. Normally the wife calls for the husband because they're hard-headed. The husband being hard-headed. EMS gets there, and I don't know why she called you. I'm not going to the hospital. I don't want to go. I'm fine. And you're looking at the patient, and they're cool, pale, and diaphoretic, and they're having chest pain. Yeah, they're alert, oriented to person, place, time, and event. You have got to make sure that you explain the medical situation. Look, based on the signs and symptoms of what I see here with your skin, temperature, color, condition, etc., the fact that you're having chest pain, the fact that you won't let me do testing, can lead to the possibility of you having further complications or death. And that is the part that needs to be documented. And that's why I'm kind of harping on this a little bit, because looking at chart reviews, that is the part that is a lot of time missing. It's person was alert and oriented to person, place, time, and event, did not want to go to the hospital, refusal obtained, unit back in service, right? Really short, sweet, and to the point. And there was nothing in there documented about their medical understanding of the situation at hand. That is what needs to be documented to make sure that you are properly protected in the event that there is an issue. So the EMT or paramedic is the one who is going to determine capacity if a patient wants to refuse. And remember that minors cannot refuse under normal conditions. The guardians can refuse for the minor, but they must have the capacity to refuse. So if you get called for a child and now you're there and the parent wants to refuse care for the child, but they're not in a capacity to be able to do that because of head injury, they're under the influence, whatever the situation may be, now they no longer have the ability to refuse for that child.